I'll start explaining all the things. So I appreciate everybody's patience with this.
Yeah, so Chelsea, this is Dr. Veltri. It's okay. Take a breath.
Thank you.
Yeah, I know it's nerve-wracking, but everything is okay. Just take a breath.
Thanks.
You're ready for
Thank
this.
you.
We can see your PowerPoint and we can hear you just fine.
Perfect. Okay. So we're going to get started then. So
All
hi,
right.
everyone. Thank you so much for being here and thank you for your patience. My name is Chelsea Flores and I am a master's student at Bushnell University. I'm actually graduating in a couple weeks with my master's in nursing education. Today I'm going to share with you the benefits of Hfnc and Cpap. So Sherry, if you can do next slide, please. And everybody, if you can mute yourselves just so there's no feedback in the presentation. So if everybody can mute their mics. Okay. So the purpose of this presentation is to provide a better understanding of high flow nasal cannula, Hfnc, and continuous positive airway pressure, Cpap. When to use these interventions, what to look for, and when to call the doctor. So next slide. So I'm hoping that one of you will be able to take away something from this presentation. Some of this information may seem like a no-brainer, but we all get in those stressful situations and sometimes we lose our brain in the moment, and it's why we ask for help. It's why we get others at the bedside. I'm a big believer that nursing is a team sport, and I feel like we all work better together when we're in it together. So my learning objectives for this presentation are that nurses will share what they have learned and build from their current knowledge to translate into their nursing practice, identify signs of respiratory distress, know when to call respiratory therapy and the doctor, identify when the patient qualifies for respiratory support, explain the differences between Hfnc and Cpap, and demonstrate the ability to use the Pediatric Bronchiolitis Scoring Tool. Excuse me. Next slide. All right. So high flow nasal cannula, also known as Hfnc, is an oxygen supply system that delivers humidified and heated oxygen at a flow rate of up to 60 liters per minute. All settings are controlled independently, allowing for greater confidence in the delivery of supplemental oxygen, as well as better outcomes when used. Additionally, there is also a better control over the delivery of FiO2. So as I just mentioned, the flow generator provides gas flow rates up to 60 liters per minute, an oxygen air blender that achieves escalation of FiO2 from 21% to 100% irrespective of flow rates, and a humidifier that saturates the gas mixture at a temperature of 31 to 37 degrees Celsius. To minimize condensation, the heat humidified gas is delivered via heated tubings through a wide bore nasal prong. So the warming and the humidifying feature helps provide comfort for the patient. Hopefully, the more comfort for the patient, the more compliance, which will lead to a better outcome. And we all know how difficult it is for our pediatric patients to keep those nasal prongs in. So next slide, please. So 5 physiologic mechanisms are believed to be responsible for the efficacy of high flow nasal cannula. These include physiological dead space, washout of waste gases, including CO2, decreased respiratory rate, positive end pressure, expiratory pressure, also known as PEEP, increased tidal volume, and increased end expiratory volume. So the physiological dead space accounts for approximately 1/3 of tidal volume of breathing. This allows for the accumulation of CO2 and a decrease in available oxygen for diffusion when ventilation is not effective in cycling inspired air with retained air within dead spaces. The high flow part of Hfnc provides an amount of air over what a patient physiologically ventilates. And what it does is increase ventilation and displaces any excess CO2 or O2. There's an increase in PaO2, which creates a greater oxygen diffusion gradient, which hopefully will improve patient oxygenation. So Hfnc creates a PEEP to the lower airways. It also allows for improved alveolar recruitment, increasing the effective available surface area within the lungs for gaseous diffusion, both to and from the blood. So in order for patients to gain that maximum benefit of PEEP from Hfnc, it is so important that they keep their mouths closed. And we usually don't have this problem for our babies who are on it. Next slide, please. So when do we use HFNC? When the patient is showing signs of deterioration, so lethargy, an inappropriate high or low respiratory rate, apnea, poor perfusion, worsening hypoxemia, grunting, head bobbing, severe retractions. A really good tool is to follow that bronchiolitis, the Pediatric Bronchiolitis Scoring Tool. And on the right-hand side, I do have an image. It's just a quick reference to the respiratory rate. It's not what this is not the exact one that we use, but that's what I found. So next slide, please. Alrighty. So this is the Pediatric Bronchiolitis Scoring Tool, and it is from our bronchiolitis pathway, and it's located at the front nurse's station. It's like under the, it's like, I always say it's like the little doctor's nook in that front area. It's right there. And what I want you to do right now is, if you can all, if you're not on your phone like I am, if you can all just get your phone out for me and just take a picture of this scoring tool. We're going to use it in our case study, and I just want you to be able to reference it. So I'm just going to give everybody a quick second to do so. All righty. So Sherry, can you go to the next slide, please? All right. So when do we contact the doctor? So usually when a patient's, so I'm a night shift nurse. So for me, sometimes I know day shift's a whole nother ballgame, but sometimes the doctor has already seen them in the ED, and they're like writing their orders and they're doing their thing. So we usually contact them when the patient's arrival to the unit, if the doctor has not previously seen them in the ER. We always usually text them just to let them know and stay in good communication. If the patient's status is worsening despite interventions, and then we discuss the next steps if there is a possible transfer to Portland and they need bubble Cpap. Next slide, please. Okay, so I know we don't see Cpap very often on our unit, but I wanted to include it in this presentation because bubble Cpap is used in our NICU, and when our patients transfer to Portland, they are placed on bubble Cpap. And so I hope like one day this is something we can actually provide to our patients on the pediatric unit so that they don't have to make that transfer and they can just get better and stay with us. But continuous positive airway pressure, airflow is introduced into airways and maintains a continuous pressure that keeps the airways open for patients that are spontaneously breathing. Positive end expiratory pressure, also known as PEEP, is the pressure in the alveoli above atmospheric pressure at the end of expiration. Cpap delivers PEEP and maintains the set pressure throughout inspiration and expiration. Now, our goal with Cpap is we want to treat hypoxia and decrease that work of breathing. So next slide, please. Alrighty, so the benefits of Cpap. Maintains PEEP, decreases that atelectasis, increases the surface area of the alveolus, improves VQ matching, improves oxygenation, and indirectly will aid in the ventilation. So the forced air delivered by Cpap helps to keep those airways patent and prevents collapse. Next slide, please. So when do we need Cpap? For us, it's when that patient's not responding well to Hfnc, they have continued lethargy, continued increased work of breathing, those severe retractions and abdominal breathing, the grunting, the head bobbing. We all know how that looks, and it gets pretty scary. Next slide, please. So bubble Cpap, another form of Cpap that we are more familiar with, and like I mentioned before, used in the NICU and when we transfer those patients to Portland. The pressure is in the circuit is maintained by immersing the distal end of the expiratory tubing in water. So the depth of the tubing in water determines the pressure Cpap generated. It's blended and humidified oxygen is delivered via those nasal prongs or nasal masks. And as the gas flows through the system, it bubbles out the expiratory tubing into the water, giving that characteristic sound. Next slide, please. So here's our case study. So I want everyone to put your thinking caps on. I got a 10-month-old that is brought into the emergency department by parents. The parents report that over the last 24 hours, the child has had poor feedings, decreased wet diapers, and has been breathing faster than normal. The child has also sounded congested over the last couple of days. The child has an increased work of breathing, noticeable intercostal, subcostal, and suprasternal retractions with abdominal muscle use. Cap refills less than 3 seconds. Lung sounds, there are crackles throughout. So in the ER, they started that IV, they got a bolus, and they swabbed the patient, and they tested positive for RSV. So should we admit this patient to the pediatric unit? Feel free to answer, maybe nod your head. And I want you guys to come to pop in and say, you know, what your thoughts are, because we're going to go through and have a discussion. So what do you guys think? Should we admit this patient? I'm hoping you're saying yes and you're nodding with me. So next slide, please, Sherry. All right. So upon arrival to the pediatric unit, vitals are temperature is 37.3, heart rate is 165, BP is 96/50 with a MAP of 65, respiratory rate is 60, SpO2 is 91% on 1 liter nasal cannula while awake, and the weight is 10 of the patient is 10 kilograms. So the patient appears agitated on exam, has increased work of breathing, abdominal muscle use, significant intercostal, subcostal, substernal, and suprasternal retractions. So they're really working. Cap refill is less than 3 seconds. Lung sounds are crackles throughout and poor air entry. So the doctor has previously visited the patient down in the ED. We have our orders. We can suction. We can start patient on maintenance fluids, strict I's and O's, MPO, and follow that bronchiolitis protocol. So what do we do next? What do you guys think? And also, what's that patient's Pbs scoring tool? So I'll give you a couple minutes to just look at the picture that I had you take, but don't panic if you don't have a chance to add it up or anything. We're going to go through it together, and we're going to talk through it on that next slides. But I'm going to give you guys a second before Sherry clicks that button to move on.
Chelsea?
Yes?
It's Becky. Can you remind
Hi.
me how old the kiddo is? I don't see it on this.
Yeah, 10-month-old.
10-month-old. Thanks.
10-month-old infant, yes. All right. So, you guys ready to move on? I'm going to go with yes. Okay, so next slide, please. Okay, so I hope you answered that we call the doctor and get them at the bedside. So that Pbs scoring tool, what it looks like is with the respiratory rate of 60, that patient's going to have 2 points. The accessory muscle use, intercostal and substernal retractions is another 2 points. When breath sounds are poor, another 2 points. The patient is agitated upon assessment, it's 1 point. Shortness of breath with activity is 1 point. Gives us a total of 8 points. So what is the next step here? What do you guys think? Anyone? All right, next slide, Sherry. Everyone's shy today.
Current lively group. I was going to say respiratory support, such as
Yeah.
HFNC.
Thank you. So we have the doctor and respiratory therapy are now at the bedside. So the patient is going to be started on that HFNC. It's 6 liters and 50% FiO2. Now, clearly, I'm not a doctor, but when you look at that bronchiolitis HFNC management pathway, the initiation parameters for starting HFNC, they say to start the patient at 50% FiO2. And the goal is that we want that patient to titrate quickly and get it all sorted. So what we want is we're going to put that patient on that high flow nasal cannula, and then we're going to get them reassessed in a couple of hours, 1 to 2 hours, with the goal to titrate down quickly and safely. And don't be like, for me, what I would say is don't be afraid to, be in really good communication with the doc. And also just with respiratory therapy, call them as much as you think that you need them there. That's what they're there for. We, like I said earlier, I'm a big team player, and I feel like in this case, we all need to be, like, nursing is teamwork. So 2 hours later, the vitals are 37.2, heart rate 115, BP 95/51 with a MAP of 65. Respiratory rate is 32, and SpO2 is 97% on Hfnc. So patients responding well. I think we can all agree on that. And I've added here, like, what are the next steps? And at this point, the hope is that this patient's going to respond well to treatment, and they're going to come off Hfnc altogether, and it's going to go great, and they're going to go home. Best case scenario. So in this case study, that's what happened. Everybody lives happily ever after. So Sherry, can you go to the next slide, please? So here's a quick overview of what we've touched on. Hfnc is primarily used on our pediatric unit. The PBST is a great tool to help guide doctors, nurses, and respiratory therapists when caring for a patient with bronchiolitis. When there is a significant status change in the patient, get that doctor and respiratory therapy at the bedside. Bubble Cpap is used when the patient is not responding to Hfnc. And like I said before, it's not something that we use on our unit, but hopefully one day it's something that we can bring to the unit to avoid that transfer. And that's all I have for you guys. Thank you so much for being here. Does anyone have any questions? My next slide is my thing of references, so we are done. But I'm going to allow for questions and discussion or hangout or whatever you guys want to do.
Kelsey,
Oh,
I
yeah.
have a question.
Uh-oh. Hi, Kathleen.
Hi. What do you think specifically we need to do on our unit to have, like, CPAP more readily available and that we can actually feel comfortable doing it?
CPAP I'm sorry, it cut out, of course. To get CPAP readily available, like bubble
Yeah.
CPAP. So I mean, I think the biggest thing, because I float down to the NICU, as you know, and I think, we need more respiratory support. And I think us getting trained on it and going through everything, and then just seeing what that looks like when we have a patient on bubble CPAP, obviously they're going to be in a smaller assignment. But I think, I don't know all the ins and outs, but this is just me being a dreamer, I guess. But if we have that respiratory support, like, my thing would be if we could get the NIC, like, I know NICU has their own respiratory, and they have those RTs that go through their unit and kind of circle through and check on all the patients on CPAP, and depending on their census and stuff, maybe we can, borrow that RT or have another one there readily available so that we can check. My preference would be obviously the NICU RTs that see that all the time, because I know in the past we've had some RTs that come to us and they're like, oh, well, I don't really work with children. And we're like, well, that's comforting. So I think that if we were to ever take this on, that would be like, I think, a requirement. But, this, like I said, this is me just dreaming.
Thank you.
Yeah, thanks. Anyone else? I really appreciate you guys coming and just dealing with my technical difficulties of it not working.
Chelsea, this is Dr. Feltry. Are we going to have a chance to evaluate your presentation?
I didn't, no, I actually chatted with Sherry, and with everything that happened with the technical difficulties, I didn't have a chance to get everything set up, but I can have Sherry send something out to the people who attended. And
okay,
then,
I was just wondering what to expect.
Yeah, sorry. And then you guys could, if Sherry can send something out to you guys, and you guys can evaluate me and then send it back to her, and it'll all be anonymous. And then that way she can filter everything, and then I can get that feedback.
Great, thank you. I appreciate that.
Yeah, thank you so much.
Mhm.
Alrighty, well, I think that we're good. Sherry, what do you think?
If there's not any more questions, I think then we can conclude.
Okay, well, if you guys who did attend, just take a peek at your email in the next couple of days and just evaluate me and let me know how I did. Give me some honest feedback. You're not gonna, well, I'm not gonna know who sent it, but you're not gonna hurt my feelings. This is something that I want to do. I want to help teach and do all the things. So I got to learn and I got to be better. So please, please, please give me that feedback. Thank you all so much for being here. I appreciate it.
Thank you.
Thank you.
Bye-bye.
Good job, Chelsea.
Thank you so much.